Good morning, everyone. Should we begin?
Yeah, I think now is a good time.
Okay. All right. So I'm Tanmay Panchabhai. Some of the new fellows probably haven't met me, but I'm one of the interventional bronchoscopy attendings here. And let me know if you can't hear me clearly, but I'm going to talk about pleural diseases. There's a lot to cover in 45 minutes. So I think I'm going to just focus on two important aspects of pleural diseases that you'll very frequently encounter in your fellowship. One is malignant pleural effusion, and second is pneumothorax. Other parts, I guess we may have to schedule other talks to go in detail, but hopefully this should give you a reasonable overview of how we manage these two conditions. So without much delay, let's begin. This is one of my favorite slides, talking about all the different procedures that you guys are going to be exposed to during your fellowship as a part of the interventional pulmonary program. And today we're going to focus on the left side, which is the pleural disease related procedures. So let's start with malignant pleural effusions. We're going to talk about a little bit about the epidemiology, pathophysiology, certain imaging features, the diagnostic yield of various procedures, and then basic concepts of how to manage malignant pleural effusions. What can we potentially do, offer in terms of continuous drainage, in terms of pleurodesis, in terms of thoracoscopy, and then we'll move on to pneumothorax. Malignant pleural effusions, as you'll see on your consult service, whenever you guys start rotating, is really a major problem in the United States. Over 150,000 cases a year. Most of the patients are terminal with malignancy, and lung and breast cancers end up being the majority of malignant pleural effusions. The median survival is poor, but we have to keep in mind that this median survival did not take into account the newer changes in management of lung as well as breast cancer and other malignancies, to be fair, which includes the immuno-oncology line of therapies, which really has changed how we think about managing stage 4 disease in most tumors, including GI tumors. And so we have to take that with a pinch of salt, that these patients are unlikely to live. And that's kind of where we come in as pulmonologists, as to how we're going to make their life better as they're going through therapy. Pleural fluid accumulates in the pleural space either via 6 mechanisms. You have lymphatic obstruction, increased vascular endothelial growth factor that increases permeability, hydrostatic pressure, you guys are well aware of that. Decreased resorption. Of course, tumor cells in the pleural space itself can create a hydrostatic gradient that will pull fluid from the lung parenchyma into the pleural space. This is a very rough diagram of where tumor deposits end up being more commonly seen, and it's usually the posterior pleura and the diaphragmatic pleura, either from direct seeding or from blood vessels or lymphatic seeding. The direct tumors tend to be contiguous with the parenchyma, whereas the seeded tumors from either neighboring structures or from blood tend to be on the posterior and the diaphragmatic pleura. Few comments on the ultrasound images that, again, you'll encounter during your consult service week. We're going to divide these into 4 separate entities. One is anechoic, and you assess the echogenicity with comparison to the spleen or the liver, depending on which side you're ultrasounding. So as you can see in the first figure, you can see the dark effusion, which is much darker compared to the spleen, which is completely anechoic. Then you have complex septated, which is the second picture, which you see complex septations between the viscus, the diaphragm, and then the flopping lung. This is seen in malignant effusions, rarely, sometimes all seen in empyemas and complex infected pleural effusions. Then you have complex non-septated, which is analogous to the hematocrit sign, where you see sediment in the pleural space. And again, on the third picture, left lower quadrant corner, you can see the diaphragm, the flopping lung, and then you see sediment in the intercostal space. This should point towards either a complex effusion related to a significant exudative process or a hemothorax. And then homogeneously echogenic effusion, which is again rare with malignant effusions, but common with empyemas, where you can't really differentiate between the effusion and the liver. And the only way to do that is to identify the diaphragm. Let's look at some diagnostic features on ultrasound for their yield in terms of a malignant diagnosis. So the couple of things that you really need to be aware of is diaphragmatic pleural thickening. If you see that your sensitivity and specificity of a malignant diagnosis is fairly high, over 70%. If you have diaphragmatic or pleural thickening, more than 10 millimeters on ultrasound or CAT scan, and then if you have pleural nodules. If you have pleural nodules, your specificity goes to above 90% for a malignant diagnosis. The question then becomes, how will that be established in terms of obtaining tissue, which could be usually is thoracoscopic. The CT features indicative of malignant pleural effusion, again, is diaphragmatic and pleural nodularity, thickness more than 10 millimeters, and absence of air bronchograms. Absence of air bronchograms gives us a fair bit of confidence that the effusion is the true problem and not vice versa, that consolidation leading to an effusion, because until you sample pleural fluid, you never know for 100% certainty that is it going to be malignant or is it going to be a complex infected pleural effusion. On the right side, you see a CAT scan and a PET scan of someone who has significant pleural thickening. And this was actually a patient of ours that I managed with your senior class who we thought initially had mesothelioma and ended up eventually having non-small cell lung cancer, which behaving in a slightly odd way, causing circumferential diaphragm pleural thickening. So let's come to yield of thoracentesis and how we're going to differentiate effusions. The age-old criteria, Light's criteria, are still valid, but in programs where we have a large volume, it becomes cumbersome to send serum labs at the same time. You're well aware of the Light's criteria. I'm not going to go over them again, but the ones that we truly follow is the 3-test rule, which comes from the Hefner paper in 1997, where you need 3 labs on pleural fluid. You need total pleural fluid protein, then you need pleural fluid cholesterol, and pleural fluid LDH. If your protein is more than 2.9 milligrams per deciliter, or cholesterol more than 45, or LDH more than 0.45 times upper limit of normal of that particular lab, so you need to know what's the upper limit of normal for our lab. If one of these criteria is satisfied, then you have an exudate. This 3-test rule identifies over 99% of exudates identified by Light's criteria, and so it's much more convenient and has good sensitivity and specificity. If you think that an effusion is a pseudo-exudate, after diagnosis of an exudate, you can do a SAG or a lab analysis similar to a SAG, where you subtract pleural fluid protein from serum protein, and if the gradient is more than 1.2, then you can label it as a pseudo-exudate. In addition, if the total cholesterol in the pleural fluid is less than 25, then the effusion is likely to be a pseudo-exudate, even if the protein or LDH criteria meet. So let's talk briefly about the yield of thoracentesis. The most common procedure performed in the pleural space for diagnosis of malignancy. If you have a lymphocytic exudate, your suspicion for a malignant effusion should be very high. The most common cancers that metastasize to the pleural space, again, are lung and breast, and the yield of different types of lung histologies is different, by the way. The highest yield is for adenocarcinomas, lowest yield is for squames. And so just because your cytology is negative doesn't mean that the effusion is benign. You probably get around about 65 to 70% at the most after doing 3 thoracentesis, starting with 65% with first thoracentesis, only if you send 50 cc's or more of fluid for analysis. And that's why you'll see us in the Bronx read or when you do thoras in the MICU, you always want to send at least 50 to 60 cc's of fluid for cytology. Doing subsequent thoracentesis doesn't really add much, and so we try not to do that unless patient truly desires. And we'll talk about what additional diagnostic approaches we can go forward with. I like to mention this closed pleural biopsy, which again is not very commonly done. I don't even think we have a closed pleural biopsy needle here at UH, but This is something that I've used at other institutions in patients who could not undergo a thoracoscopy, and you really need a tissue diagnosis to establish a malignant process. This is basically a blind pleural biopsy where you put in a trocar and then put in a biopsy tool through the trocar and hook onto the pleural space above the rib, to basically get the tissue that you can reach using the biopsy tool. The way I like to do it is I usually like to put in a chest tube first, in the posterior aspect of the lung, so that if you do cause an intercostal bleed or a hemothorax, you have something that's continuously draining the pleural space at the same time. And you don't risk the patient having a fibrothorax because of an entrained blood clot. As you can suspect, in malignant disease that's not uniformly distributed, the yield of closed pleural biopsy is quite low, and so we don't do it. But in benign diseases, especially tuberculosis causing pleurisy, the yield is actually quite high, almost over 80%. The next way to diagnose effusions is by doing thoracoscopy, and this could be done either with a single port or multi-port. The medical thoracoscopy part is done by interventional bronchoscopists. We are still in the process of trying to set this program up at UH. COVID has delayed us quite a bit, but I hope that we should be up and running this year. We do this under deep sedation, and we basically induce a pneumothorax by opening up the intercostal space with one port. And we do limited interventions here with pleural evacuation, adhesionolysis, pleurodesis, and biopsies. Whereas VATS is always done in the OR, needs a double lumen endotracheal tube because you have to put the lung down on the side where you want to intervene in the pleural space. And then you can actually do multiple interventions involving the lung and pleural space because you have a couple of ports where you can actually look from one, intervene through the other, and use the third one for hemostasis, cautery, etc. The yield of medical thoracoscopy for malignant effusions is about 92 to 93%. VATS gives you a better yield of 3% higher because you have better exposure of the upper parts of the lung, especially. In patients who have pleural nodularity, the CT-guided approach is not completely unreasonable. I'm not a big fan of it because usually if the pleural space is traversed and you don't have something draining the pleural space, you kind of leave the patient alone without really having a backup plan in case there's bleeding into the pleural space. But if the nodules are very large, or if it's a circumferential thickening, like in mesothelioma, it's not an unreasonable approach. We talked about thoracentesis and how the cumulative yield is 75% tops, and we talked about closed pleural biopsy. I'm going to skip the videos of thoracoscopy for interest of time because we have to cover a lot in 45 minutes. Now let's come to the therapeutic aspects of malignant pleural effusion, and this is where most of the decision-making really happens in terms of management. Is your first question that you want to answer for yourself is, a patient with malignant effusion proven, is the lung expandable or no? And then you want to see whether the patient's lifestyle choices and survival prediction allows you to use pleurodesis, either indwelling pleural catheter or Pleurex or both, and which are the patients who are good candidates for thoracoscopy, and a little bit about cost of care. I would encourage you all to read the statement by ATS and the Society of Thoracic Surgeons, which talks about the PICO approach to management of pleural effusions. We'll briefly talk about it in the interest of time. So the first one is where in patients who have known or suspected malignant effusions, should we use ultrasound to guide pleural interventions? The recommendation is yes, class 1A. In patients who have suspected MPE or defined MPE who are asymptomatic, should pleural drainage be performed? The answer is no, unless your stage of the patient is going to change by demonstrating that there is malignant disease in the pleural space. Should patients who have symptomatic or suspected MPE, should management be guided by large volume thoracentesis and pleural manometry? The answer is yes. So we usually try to do this as our first intervention. You could do manometry by continuous flow monitors, which are expensive, or poor man's technique by zeroing the pleural space at the level of entry of the catheter and then measuring pleural pressures every 200 to 300 cc's. We routinely don't do this. We rely more on the patient's symptoms in terms of how they cough, and I like to do drainage pretty much always by gravity, which doesn't put a lot of strain on the pleural space and really gives you a good idea whether the lung is expendable or not. In patients with symptomatic MPE and expandable lung with no prior definitive therapy, can we use IPC, which is indwelling pleural catheter, or chemical pleurodesis as first-line intervention? And the recommendation is either. Depends on a lot of things, depends on patient's quality of life, what they really like. And we'll talk about what activities one can perform with post-pleurodesis and what can they perform with an indwelling pleural catheter. Then in patients with MPE undergoing talc pleurodesis is puderage, which means insufflation of talc thoracoscopic or talc slurry. Which one is better? You can actually use either, except in lung and breast, where puderage has been shown to have better outcomes. In patients with MPE with non-expandable lung or failed pleurodesis or loculated diffusion who are symptomatic, should IPC or chemical pleurodesis be used? And the data favors using indwelling pleural catheter. And in patients with IPC-associated infection, should medical therapy be used or catheter be removed? And the answer is you always treat the pleural infection. You have something draining the pleural space, so the catheter does not need to be removed. For the first years, this is a quick summary of how indwelling pleural catheter works. This is a tunnel catheter that goes into the pleural space, and you'll get ample experience of this during your fellowship to place Plurexes. It has a one-way valve, and so fluid can only go from the patient to the bottle when the valve is opened. Otherwise, you can't really have flow in the other direction, preventing a pneumothorax. There's a couple of brands. Plurex is the most commonly used one in the US, and that's the one that we have here at UH. The catheter comes out anteriorly so that the patient can actually drain himself or herself. And it's usually covered by a sterile dressing. And because of the placement and where the catheter comes out in the anterior chest, patients with IPCs are not allowed to swim, and they can't sit in a hot tub. This is where the lifestyle modification that I talked about comes into play. Which patients can actually undergo pleurodesis, and what tells us what factors will be responsible for good pleurodesis? Well, pleurodesis basically involves creating intense inflammation in the pleural space, so we can let the visceral and parietal pleura stick to each other. We have data that suggests that small bore chest tube is equal to large bore, so you don't really need a large bore chest tube. For successful pleurodesis, you need complete expansion of the lung. So you want to demonstrate that the lung is expandable with less than 150 cc of daily drainage. So you should be able to keep the chest tube clamped for 2 to 3 hours after pleurodesis without the lung dropping. You don't really use corticosteroids, and patient rotation that was done previously is no longer recommended. For those of you who were on the consult service last week, we did pleurodese someone with a malignant diffusion where we couldn't place a Plurex, and I think they got a good experience. I think Martin was the one who did the pleurodesis. So the two agents that we use a lot is talc. You want to use about 2 to 5 grams of talc at one time. It's given as slurry through the chest tube itself. Initially, we numb the pleural space by giving lidocaine, and you always pre-medicate the patient with some pain medications. If that doesn't work, then my favorite go-to agent is 10% iodine, which has excellent success in achieving pleurodesis. And you'll gain more experience about how to reconstitute these agents and what's the total amount that's instilled in the pleural space during your training. So key questions to be answered in malignant pleural effusions are, is chest tube pleurodesis better or VATS pleurodesis is better? Then question 2 is chest tube pleurodesis better versus indwelling pleural catheter? Should we place indwelling pleural catheter versus do indwelling pleural catheter plus pleurodesis? Or should we do pleuroscopic or thoracoscopic pleurodesis plus IPC plus talc? This may be a little too much in detail, so I'm just going to go briefly over the studies so you at least know what are the studies that you need to review in the upcoming months. So the chest tube pleurodesis versus VATS pleurodesis, this was a seminal trial by Dressler published in Chest, where they compared talc-putaraj, which means insufflation with a pump of talc in the pleural space thoracoscopically, versus giving chest tube slurry, which means reconstituted liquid talc through the chest tube. And then we had the time to an ample randomized control trials with answering similar questions. And what we found was in the Dressler study that the overall effusion recurrence in 30 days as well as life expectancy was no different in patients who received putaraj versus slurry. So you can basically pleurodese the patient at bedside and they don't need to go to the OR or endoscopy suite, except patients who had lung cancer and breast cancer, who did significantly better compared to other tumors with putaraj. And so these are the two indications where, if possible, you should consider talc insufflation when you consider pleurodesis as an option. The next question to answer is whether CT pleurodesis is ideal versus indwelling pleural catheter. And we had two studies that looked at this. One was the Time 2 randomized control trial, and they randomized IPC or indwelling pleural catheter to talc slurry. Primary outcome was VAS score, which is basically an organic way of assessing outcomes, complex outcomes at 42 days. And they found that there was no difference in dyspnea at 42 days between IPC and talc. There was no difference in quality of life. However, patients who had indwelling pleural catheter had significantly more interventions compared to folks with talc. And this is because of catheter clogging, catheter infection, catheter dislodgement. And the adverse events in the IPC group were also significantly high. The IPC group did have slightly better scores than the talc group at 6 months, but there was a little bit of a bias of sicker patients being included in the talc group. So the conclusion was really no difference between pleurodesis and IPC. And so we want to make sure that our decision-making is in line with the patient's overall goals of care. Shorter hospital stays with IPCs are evident and obvious because this procedure is done as an outpatient procedure where the patient goes home the same day, whereas talc insufflation usually requires admission to the hospital with at least 2 to 3 days post-procedure stay. The next study looked at indwelling pleural catheter versus talc pleurodesis, which was called the ample randomized trial. And here, the talc pleurodesis was given again via chest tube, and primary endpoint was total number of days spent in the hospital from procedure to death, along with other secondary measures. And what was seen was the all-cause hospital days were lower by 2 in patients who underwent IPC versus talc. And 2 seems like it's a small number, but in patients who have an overall survival of 4 to 5 months, 2 days spending at home, I would think is not unreasonable to proceed towards IPC. Further interventions were much less in patients who had IPC versus talc slurry pleurodesis. Now remember, this was talc given through chest tube and not given thoracoscopically. Adverse events were slightly higher in the IPC group as suspected in other studies as well. Next question was, can we do indwelling pleural catheter versus IPC plus pleurodesis? And this was the IPC plus study, where what they did was in patients who had expandable lung, they placed an indwelling pleural catheter, and through the indwelling pleural catheter, they actually did talc pleurodesis on an outpatient basis, which is pretty good in terms of a study design. And what they found was in patients who had indwelling pleural catheter plus talc, their pleurodesis rate was significantly higher compared to IPC alone, over 50% at 70 days. And other outcomes, including hospitalization and interventions, remain the same. So this is a potential option in patients who don't want to be admitted, want to have an indwelling pleural catheter, yet want to be considered for pleurodesis and catheter removal at some point of time. And the last one is what we call the rapid pleurodesis protocol. This was a study done at BI where patients were admitted for medical thoracoscopy. The pleural fluid was evacuated, and under moderate sedation, 5 grams of talc was aerosolized into the pleural cavity, and an IPC was placed at the end of the procedure. So the patient has a 24-French chest tube and an indwelling pleural catheter placed at the time of pleuroscopy, and they come out with 2 tubes. The first tube, which is the large bore chest tube, is removed in the first 24 hours. Both tubes are kept to suction for the first 24 hours. And then the patient can potentially be discharged home in 24 to 48 hours with daily drainage of the IPC on postoperative day 1, 2, and 3. The idea is to keep the space as dry as possible to make sure that the visceral and parietal pleura stick to each other and successful pleurodesis is achieved. And if in a week's time, if there's no fluid that's coming out of the pleurix, you want to troubleshoot, make sure that the pleurix is patent, and that's why fluid is not coming out. So you ultrasound or do a CAT scan, make sure that there's no accumulated fluid. If there is no fluid and the lung is expanded, then you remove the IPC and the patient is pleurodesed. Median hospital stay with this approach is about 1.7 days compared to 3 to 4 days with a standard thoracoscopic approach. And successful pleurodesis happens in 92% cases, which is a really worthy outcome. When we talk about cost, this is data from Medicare reimbursement. We always have to be fiscally responsible when we think about what interventions are going to be offered to patients. So when we use talc pleurodesis, the cost is significantly lower by about $840. Pleurex is cost effective if the expected survival is less than 6 weeks. If the expected survival is more than 6 weeks, then IPCs or pleurex catheters, the ones that we use here, are not cost effective because the supplies and the cost of the visiting nurse adds up. And so that should somewhere factor into your overall decision-making process as to what intervention is offered. But this is a very rough schematic dogma about how malignant pleural effusion should be approached. So if you have someone with a malignant pleural effusion, if they have no symptoms, you're done. Unless required for staging, you don't really need to tap that fluid. If you have someone who has a malignant pleural effusion and they're symptomatic, they undergo thoracentesis. If the dyspnea is better, well and good, then you move to the next step. If the dyspnea is not better, so basically they did not feel better after thoracentesis, then really there's no indication for further interventions or placement of catheters for drainage. If the dyspnea is better, then you want to answer to yourself, is the lung expandable or not expandable? If the lung is not expandable, then you want to see what is their overall survival. If the survival is less than 2 weeks, then there is no point in placing an indwelling pleural catheter. Patients needs to consider hospice. If the survival is more than 2 weeks, but less than 6 weeks, then you can consider placing an indwelling pleural catheter. In expandable lung, the intervention choice depends on patient's preference, and this preference includes how active they are, how many times they go for a swim, do they really need to sit in a hot tub, are they really outdoorsy folks who want to maintain that quality of life. If that's the case, then you really want to avoid an indwelling pleural catheter and want to focus on pleurodesis, either thoracoscopic, or you could do chest tube pleurodesis. You could do a combined rapid pleurodesis protocol. Some patients prefer not to get admitted to the hospital, yet want to be pleurodesed. So in those folks, you could consider placing an indwelling catheter and then pleurodesing through the indwelling catheter, similar to what was done in the IPC Plus study. This is a rough background. As you rotate to the console service, you'll understand the nuances of this process a lot more. Okay, so let's move on to pneumothorax. This is going to be a short one where we look at the common causes. How are you going to drain the chest when there is air accumulation, either by chest tube or by needle decompression? How do you identify tension physiology, and treatment options briefly for prolonged air leak? So a few definitions. We need to be very clear about what is a bronchopleural fistula and what is an alveopleural fistula, because it's frequently confused. So on the left side, you see a lung that is deflated because there's an apical pneumothorax, and you see that the bronchus, the right upper lobe bronchus, is directly connected to the pleural space. This is called a bronchopleural fistula. This is much harder to treat, and usually does not respond to bronchoscopic interventions, or even time. To be honest, this oftentimes will require surgical intervention, and the most common reason for a bronchopleural fistula is also post-surgical, usually after lobectomy. This, on the right side, you see the lung space opening into the pleural space, which is the alveolar sacs. And this is called an alveopleural fistula, which is much more common as a result of trauma, as a result of procedures, as a result of pre-existing lung disease. And this kind of a pleural fistula is much more likely to respond to conservative measures, to time, to potential therapies like endobronchial valves, and also to pleurodesis. You guys know the etiology of pneumothorax. The most common ones in the hospital that we worry about is central line insertions, lung biopsies, pacemaker placements, and of course, surgical procedures. Traumatic, then you have spontaneous and secondary spontaneous. So most common cause of iatrogenic pneumothorax in hospital settings is subclavian venous catheterization. The rate is almost double the rate of IgA-related pneumothoraces, and even thoracentesis for the matter of fact. And it's interesting that teaching hospitals, of course, have a higher rate of pneumothorax because trainees are learning how to place these catheters. So I always tell the fellows when I'm rotating on the ICU that if you have someone with a chest tube and they need a line, you should always, always, always think about learning how to place a central subclavian line, because you don't get to do it too often. But if you're good at it, it's actually a really good vascular catheter to be comfortable with. As I said, subclavian lines are the most common cause of iatrogenic pneumothoraces in the hospital. But there are also catheters that get least infected. And so it's one of my preferred central catheterization approaches if the patient is stable, and if especially if they have a chest tube on that side. So plain film cues for pneumothorax, things that you should be looking for. Well, of course, you should look for subcutaneous emphysema. You should look for associated injuries, rib fractures. We don't see this very common in the patients that we deal with. A deep sulcus sign where the ipsilateral sulcus looks way deeper than the contralateral sulcus, where air is not accumulated in the pleural space. Look for mediastinal shift. An upright film will detect about 50 to 60 cc's of air, and a supine film will detect almost 10 times, 500. So you need an upright film. With ultrasound, really, the utility of upright film is kind of a moot point, because you should be able to diagnose this by ultrasound alone. Now, ultrasound, we know, is much more superior to diagnose a pneumothorax than chest X-ray. There's multiple studies to prove that. So how do you diagnose it? Well, you use your linear probe. You want to place the probe at the apical angle of the lung so that it actually images two ribs. You'll see two rib shadows and then pleural line in between the rib shadows. So this is a schematic representation where you see rib on either side and the pleural line in between. And you can see a faint hint that the lung is sliding, although this is not a video, it's a static image. Then there's two signs over here called seashore sign and stratosphere sign. The seashore sign is what normal pleura results in. So pleura that causes lung sliding causes an artifact that results in the lower layers not being imaged correctly, and it looks like a very sandy, grainy seashore. When there is a pneumothorax and lung sliding is absent, that artifact disappears, and you basically get what's on the right called a barcode or a stratosphere sign. Lung sliding, by and large, is the most important thing that we look for. We don't usually try and find these signs, especially if the clinical picture makes sense. So ultrasound findings that can suggest a pneumothorax are the following: absence of lung sliding, absence of lung pulse, absence of B lines that you should see if the lung is expanded. We talked about the stratosphere sign, and presence of lung point, where you basically see sliding up to one point of the pleural line and absent sliding on the other side. That is a little tough to demonstrate, but if you're able to, it's much more specific for diagnosis of a pneumothorax. Now, you remember, you have to be careful because lung sliding can be absent in patients who underwent pleurodesis, if they have bronchial obstruction where the pleural line is not in contact with the parietal pleura, poor inspiratory effort, if they have malignant infiltration of the pleural space, if they have emphysema. Pleural sliding is frequently absent in lung transplant recipients because they have, especially if they've had a double lung transplant, because they have a single buffalo chest and the pleura is quite frequently injured during the procedure, the surgical procedure. And then, of course, vigorous movements of the intercostal space can be mistaken for sliding in someone who is in severe respiratory distress. You have to be careful about those things. So first step, assess for cardiopulmonary compromise, assess for hypoxemia, tachycardia, venous distension, tracheal deviation. You guys know all of this as to how to handle someone with the tension physiology in the ICU. First step, you want to stabilize the patient. You can move forward with either needle decompression or tube thoracostomy. The most common location where I recommend you placing a needle to decompress or a chest tube is the second intercostal space, is where air rises and your chance of injuring the lung is least. The triangle of safety, which is the fourth, fifth intercostal space in mid-axillary line and anterior axillary line, basically the triangle bounded by the pectoralis major muscle anteriorly and the latissimus dorsi posteriorly, is usually meant for surgical chest tubes. It can be used for needle decompression in emergent settings, but keep in mind, you don't know when someone has a pneumothorax if the lung is tethered or not. And if the lung is tethered, you could potentially place a tube in the lung. Doing needle decompression and placing a needle in the lung is not that big of a deal. It will eventually heal, but putting a chest tube in the lung is not a good thing. And that's why the safest place to place a tube is the second intercostal space, mid-clavicular line. Now, needle decompression can be life-saving, but it has high failure rate, and that's why tube thoracostomy is the ideal way to go. This is a representation of how a chest tube is placed surgically. We don't do this very often in the ICU. Once we start doing thoracoscopy downstairs in the suite, you guys will get experience of placing surgical chest tubes where you go above the rib and you basically manually dissect until you enter the pleural space. You see a gush of air and you use your finger to make sure that the lung is not tethered to the pleural space. And then with the Kelly over the rib, you want to slowly direct the tube into the pleural space so that it's directed apically. Then is the second chest tube technique by Sellinger's technique, where we basically make an incision similar to a thoracentesis. You want to put in a tube over the rib. After aspirating air, put in a guide wire, dilate. The reason that this tube is slightly not in favor for placement in the triangle of safety. Again, you don't know when the lung is tethered over there. And when you do a Sellinger's technique chest tube, you don't have the ability to ensure with your finger that the lung is not tethered. So you're just guessing that wherever your wire is going, because you got air initially, that it's still in the pleural space and it's not actually going through and through the lung. So you have to be a little careful about which location and which tube you're going to place. Other than that, I think these tubes are fantastic. We use them a lot for effusions, for pneumothoraces, a bunch of things. Basically, your Pleurex is a similar kind of tube, just has a tunnel to prevent infection and has a cuff to keep it in place. So key facts about pneumothorax management: tube size does not matter. So large versus small, success is equal. Complication rate is higher with the large bore chest tube, and data favors using small bore chest tubes. Usually 14 and 16 French tubes is what we use for initial management. Now, tube size can matter if you have someone who has trauma and a concomitant hemothorax, in which case you should consider using a large bore chest tube. Sometimes if the pneumothorax is large, then you don't have enough egress of air with a small bore chest tube. And so it's important sometimes to upsize the tube. Now you have to keep in mind that these small bore chest tubes frequently get clogged. And so one of the things that came out of data from the MIST study and other studies is that you have to flush these tubes at least once a day, ideally twice a day. And so when you rotate with me, you'll see how particular I am about making sure that these tubes are flushed, because only then you can assure that the tubes are patent. You all know the 3-chamber system that we use as a Pleurovac to make sure that the complete wall suction is not applied to the lung, and there's a water seal, and the column of air in the water seal basically tells us how much negative pressure is applied to the lung. These are 2 atrium chambers that you'll see. We use the one on the right side here at UH. Again, you have to make sure that the water seal chamber has water in it. And there's been some times where tubes have been placed and nurses have changed chambers and there's no water in the water seal. At that time, you basically are connecting the patient's pleural space to external suction, which can cause significant trauma. How do we measure air leak? Well, the most commonly used classification is called the Serfolio classification, which divides it into 4 grades. And sometimes we'll ask you as to what grade it is when we're rounding on the consult service. Grade 1 and 2 are with forced expiration and expiration only. Grade 3 becomes even more severe, so it's inspiration and expiration. And grade 4 is continuous. And that's the leak that usually is the biggest problem. You can measure the flow of the leak by an actual flow meter. Oftentimes it doesn't really help much in terms of management, so we use the clinical classification. If someone has a grade 1 or grade 2 leak and the lung does not deflate with coming off suction, then you could potentially send them home with a pneumostat. And this is a pictorial depiction of how a pneumostat looks. What does it have? It has a chest tube connection. It has a belt clip, a chamber collection for pleural fluid, and then a sample port. And the pneumostat is a one-way valve, so air can only go from patient to outside and not the other way around. Now, suction during management of a pneumothorax, it's a double-edged sword. Ideally, you want to minimize it because the more you keep on sucking air through the defect, that defect is going to remain patent. However, if you put the lung chest tube to water seal and the lung deflates, that tells you that the patient does not have the intrinsic ability to ensure that the pneumothorax is drained spontaneously without suction. So it has to be assessed on a day-to-day basis. Surgical management of leaks, prolonged air leaks, is usually the mainstay, where you perform VATS, identify the defect, and apply a staple across the defect to basically close the defect off and let the lung expand. Another adjunct is pleurodesis, which you can use either mechanical or chemical. The issue is, for chemical pleurodesis through chest tube, you have to have lung that doesn't deflate. Because after pleurodesis, for pleurodesis to work, the visceral and parietal pleura have to be in contact for at least 2 hours. And so if you have someone who cannot come off suction, then it's very unlikely that pleurodesis can even be attempted in that patient. So you have to have someone whose lung stays up on water seal. There's 2 valves that are also approved for use in prolonged air leaks. The spiration system is the one that's most commonly used. It's an easy procedure to do and rarely successful. And the reason is the lung has collateral ventilation, and sometimes the fissure between the upper and lower lobe on the left or the upper, middle, and lower on the right is not complete. And what that means is that even if you obliterate the lower lobe, because you know that the leak is coming from the lower lobe, the lower lobe can still be ventilated through collateral ventilation from the upper, which makes your procedure useless. And that's why we don't do this a lot of times, because it's not very successful. If someone really is not a good surgical candidate, it's reasonable to try it, but these valves are very expensive, and so it has to be carefully evaluated before valves are considered for management of persistent air leaks. Now, another thing that you can do is blood patch pleurodesis, where you actually use the patient's own blood and autologously transmit it into the chest tube in a sterile way. Again, for this to work, the lung has to be up, meaning you cannot have lung deflation on water seal. And the way it's done is, in a sterile way, you establish a new vascular catheter, which is either a midline or a PICC line, obtain blood, and immediately transfer it in a sterile way to the chest tube. most common complication is infection, which is about 6 to 10%. So I usually administer prophylactic antibiotics. But actually, if the blood patch works, it works really well and works sometimes better than chemical pleurodesis. So basically, my approach to non-tension, if it's small and stable, you monitor. If it's big and growing, you put in a tube. And these are the key learning points that we went over. So always use ultrasound. Assess cardiopulmonary compromise. If there is tension in pneumothorax, you want to always drain the chest. Don't worry about the lung injury, drain the chest. Needle decompression can be life-saving. If it doesn't work, then tube thoracostomy. And in prolonged air leak, surgery is option number one. If patient's not a surgical candidate, we can consider valves, but they don't work very well. Okay, thank you. I can take questions.
Anyone have any questions? I'm going to take that as a no.
Okay,
Thanks, Dr. Panchabhai.
thank you.